Welcome to Indo-Bangladesh joint session. It is a great occasion that this session has been planned to mark the long cooperation between Bangladesh Pediatric Association, Pediatricians of Bangladesh and Indian Academy of Pediatrics and Pediatricians of India, especially West Bengal. May I thank Dr. Pallab Chatterjee, Dr. Subhashish Rai, and the whole team who have organized this beautiful conference we are enjoying now. And today we have 3 presentations, and after that panel discussion. May I request Dr. Jobar Sisty to come up on the dais and to present his paper, Locally Made Low-Cost Bubble CPAP in Treating Childhood Severe Pneumonia and Hypoxemia.
Thank you, sir, for your so nice introduction. So, my dear and respected panelists, and my dear teacher, Professor Rulamin, sir, and my dear teachers here and other colleagues, Assalamu alaikum. So the topic of my presentation today, you see that the locally made low-cost bubble continuous positive airway pressure in treating childhood severe pneumonia and hypoxemia, I want to give an evidence-based update. As I'm sure most of you know that childhood pneumonia, especially under 5 pneumonia, is one of the leading infectious cause of under 5 mortality globally, especially in lower and middle income countries, and especially in sub-Saharan Africa and Southeast Asia, including Bangladesh, India, Nepal. And if you see that the reduction of pneumonia-related mortality starts mainly from 2000, and from 2000 to 2018 and 19, there is significant reduction of pneumonia-related mortality. It is around 54%. However, if you contrast the reduction of mortality from other diseases, you can find that except sepsis, the reduction of pneumonia-related mortality still lag behind. And if you see the Bangladesh scenario, you can find that we had a very steady reduction of mortality from 1990. And we are one of the rare countries in the developing world who actually achieved Millennium Development Goal before its achievement period. However, if you see after that Millennium Development Goal achievement, the pneumonia-related mortality was estimated to be reduced up to 2021 very steadily, but it is not the case. In 2018, we have found that in Bangladesh, the pneumonia-related mortality was 24,000. That does mean that we are in static position after achievement of the Millennium Development Goal. That does mean that we need to do something better in Bangladesh, in Southeast Asia. So, who is the main culprit to causing this mortality? It's among the other risk factors. If we see the main etiology of death, we can find that in a recent systematic review which involved 17 studies, especially from the developing countries, including 2 studies from Bangladesh, it has been found that children who had pneumonia and hypoxemia compared to those who didn't have hypoxemia had more than 5 times the risk of death. And if we see the prevalence of overall hypoxemia globally, it is 31% among the hospitalized cases. And if you see the Bangladesh scenario, it is much more worse. It is around 40% among the hospitalized cases. That does mean that we need to manage hypoxemia efficiently to reduce the pneumonia-related death. So what is the scenario of hypoxia management in developing countries? If we see the WHO recommendation, you can find that WHO recommends low flow oxygen for the management of hypoxemia, especially pneumonia-related hypoxemia. And it is true that WHO recommended oxygen should no longer be considered as supplemental therapy. It should be considered as one of the essential drugs. And since then, it is associated with 35% reduction of mortality in the case of pneumonia management. However, even with that reduction of mortality, and nowadays we find that in many hospitals in developing countries like Bangladesh and in India and Nepal, we find that pneumonia-related mortality with WHO standard oxygen, WHO standard antibiotic, and other routine care is more than 10%. That does mean that we need better oxygen support compared to WHO1. In search of that, we thought that continuous positive airway pressure might have an alternative option. However, it can be generated by the different ways. And what we have found that conventionally, mechanical ventilator driven continuous positive airway pressure, that is the CPAP, can be generated. But in developing countries, scenario like Bangladesh, especially in district hospitals, even in tertiary hospitals, the availability of mechanical ventilator is not so easy because it is not only expensive, but it does also need special training for the doctors and nurses. So we thought that we should have something which is affordable and sustainable. So we found that bubble continuous positive airway pressure is one of the options. However, it was invented by Professor John Gregory in 1970, especially for the treatment of acute respiratory distress syndrome. You know that the pathology of acute respiratory distress syndrome and pneumonia is not the same. So we thought that what can be done? So we thought that we need to know whether there is any work or someone has done something to see whether it does work or not. And we simultaneously also wanted to see that high flow nasal cannula has any role or not. And you know that it already is very established in the developed countries, especially in children with bronchiolitis, to reduce the indication of mechanical ventilation. So we had done a systematic review to understand the present scenario of bubble CPAP. We have found that neither bubble CPAP nor high flow nasal cannula was tested, especially in case of severe pneumonia and hypoxemia beyond the neonatal period. Then we had designed a randomized trial, first randomized trial in Bangladesh, comparing WHO nasal, WHO recommended oxygen compared to bubble CPAP and compared to high flow nasal cannula. And our bubble CPAP was not so fancy. We have simplified the version with, you can see that WHO nasal prong with a water-filled plastic bottle and with a part of a saline set. It only cost around $2. What we have found that it is not only associated with the reduction of 73% treatment failure, it is also associated with 75% reduction of mortality compared to WHO standard one. And if you see the trend of reduction of mortality from bubble CPAP compared to high flow nasal cannula, there was clear-cut trend, but it didn't gain the statistical significance. However, after publication of our results in the Lancet, an enthusiastic group of intensivists from France and statistician further analyzed our data using Bayesian advanced model. And they showed that bubble CPAP was not only better than the low flow, it is also better than the high flow nasal cannula oxygen therapy. That does mean that it has a huge implication in reducing mortality. So we incorporated bubble CPAP, which is the part of the standard of care in the Dhaka hospital where the original trial was designed. And after 5 years of implementation, we wanted to see whether bubble CPAP has the same kind of impact. And we compared this with the pre-trial period and trial period. And what we have found, before going to see the impact, we wanted to see the baseline characteristics of 3 era. What we have found that the children with younger age are more during the pre-trial period compared to the post-trial period, and immunization was better covered in the post-trial period compared to the pre-trial period. However, we found that the danger signs of pneumonia as well as severe respiratory distress signs were significantly higher among the post-trial period compared to the trial and pre-trial period. And after adjusting all those age, immunization, danger signs, and severe respiratory distress, we found that bubble CPAP has a significant impact of reducing mortality compared to the pre-trial period to the post-trial period. It is not only associated with the reduction of mortality from severe pneumonia and hypoxemia, it has an impact in the overall hospital mortality from pneumonia. That does mean that it is well organized and worked in case of hospital settings, in tertiary setting. Then we wanted to know whether it can also replicate it in secondary hospital settings. And before going that, you know that scientifically we need to understand the feasibility, and we have found that the feasibility, it is also feasible in the district hospitals, not only in Bangladesh and also in Ethiopia. And from that point, we concluded that bubble CPAP can be implemented not only in the district hospitals, not only in the tertiary hospital, but also in the district hospitals. And if it can be implemented, it is a huge impact of reducing global pneumonia mortality, and it might have an impact to actually attain the sustainable development goal by reducing pneumonia mortality from 0.8,000 to 0.25 million by 2030. And you will be pleased to know that Bangladesh has achieved a lot of international awards for this development, and it is going to be implemented and scaled up in Bangladesh and in Ethiopia and globally where pneumonia mortality is high. And hopefully it will not only have the award, it will be awarded by the reduction of mortality from the global pneumonia. Thank you very much for your patience hearing.